The Big Show with Glenn and Angel on Kiss 92.
Good morning.
Sometimes getting out of bed in the morning is a lot to deal with all at once.
Good morning, Singapore, and welcome to the biggest and best breakfast show in the world. And one of the reasons why we are the best is because we have the best guests. Today is going to be very, very interesting indeed. I've been looking forward to this, and finally I get to meet him in the flesh. Professor Theodoros Kofidis, Cardiothoracic Surgeon from Mount Elizabeth Hospital. Welcome to the Big Show.
Good to be here. Good morning, everyone.
Good morning to you.
Thank you so much for coming in. Now, today specifically, we're talking about how open heart surgery doesn't need to be so traumatic and large when it comes to leaving scars on the body. So it's been used to treat conditions like coronary artery disease as well as heart valve issues. So how does your new surgery method or methods differ from the heart surgery that we're used to? Could you explain that?
Absolutely. Well, you'll be surprised to know that it's not that new. Minimally invasive heart surgery. That means avoiding median stenotomy, avoiding chopping open the sternum. Exists since 1995, mid-90s, 96. Started from France and Germany and started then distributing around the world. Back in the day when I was the head of department in NUH, we started the program, brought the best and newest there is around the world, both in terms of technologies as well as techniques. And we set up the minimal invasive program, which now I transferred out to Mount Elizabeth. So the techniques in it themselves exist, as I said, for more than two and a half decades. Now, the people view the median stenotomy as the traditional way to do things. But with time, people change, patients change. Characteristically, let me say that 30 years ago, people were praying to come out alive from heart surgery. 10, 15 years ago, with technology advanced, better surgical skills, better techniques and tools, patients expected not only to come out alive, survive, but have the least possible complications. Nowadays, they're even more educated. The first thing they ask me, hey, doctor, when can I go back to work?
Wow.
When can I go back to business, So they expect to come out alive, least complications, and have the least possible trauma. So the minimal invasive heart surgery changes the entire patient experience. Because the chest bone is not cut, that means the chest cavity is not destabilized. Patient painless, mobilizing much faster, going home faster, better breathing work, better lung function, less bleeding. There's a lot of advantages basically that the patient benefits from.
Right. You're going to get to see a lot of photos later on the Big Show TV. But before we go back on the Big Show TV, why is it so much safer these days? What's the process like?
Okay, there's more protocol, there's more experience, obviously, and I'm including the open heart surgery to that as well. Heart surgery has advanced a lot. The standards have improved. As in any other aspect in life, technology facilitates it. The skill is advancing. So along with the increasing and changing expectations by our patients, we also improve with better technologies, better standards and protocols.
Right. Okay, stay with us. You're going to see some amazing things on the Big Show TV, okay? We are speaking to Professor Kofidis this morning right here on Good Morning Doctor. Okay. Now, perhaps, Professor, you can, go through some of the photos that you've sent us. You mentioned earlier on about how it is minimally invasive now, and so that means less scarring. So
what we see here, for example, if you don't mind, so instead of opening the chest bone right in the middle, you see we conduct the surgery by small cuts on the right side of the picture, side from the picture's perspective. If you look at the picture, the left one, with the two tools inserted, that's how we do the mitral valve procedure, through a small cut between the fourth and the fifth rib on the right side. I just did two of those cases, Monday and Tuesday, yesterday, the day before. So we don't open the chest bone, basically. From the right side, some people may think, hey, how come the right side to reach the heart? Well, for each structure in the heart, you must know how to enter and where to enter exactly. So for the mitral valve repair, replacement, also for the tricuspid valve, the heart has 4 valves.
Yeah.
You enter from there. So for the bypass procedure, you enter from the left side. You see the other portion of the picture, the patient lifting his shirt?
Yeah.
That is the incision we need to do to get to the heart and conduct the bypass surgery.
Right, okay.
So it's about 6-7 centimeter incision below the left nipple, between the 5th and the 6th rib on the left side. So we don't break bones, we don't break ribs or the chest bone, as I mentioned. Hence, that improves the entire recovery period of the patient. Their recovery experience is a totally different one.
How amazing is that? As opposed to, because one of my uncles had to go for bypass surgery, and I think it had to cut right through. And so when he came back and showed us what he had gone through, it was scary.
Yeah. How long is the recovery process now compared to before?
Okay, so if you do the surgery minimally invasively or endoscopically, that means small cut by using camera, looking inside with a camera. Here we see the comparison between the minimal invasive and the open heart surgery. It is about 3-4 days after the surgery for the minimal invasive one that you can go home. Now, the difference in the hospital is not the key. Maybe if you do a median sternotomy, you can also recover in 5-6 days in the hospital. It's what comes after. So if you have a median sternotomy, the sternum is cut open, then you have to watch which side you sleep. You have to watch that you don't carry heavy luggage. You cannot ride a bicycle. You cannot drive. You cannot swim for quite a long time. So you are sort of limited in your mobility. Right? Okay, and it's natural, isn't it? So big trauma, less mobility, more burden for the patient to overcome. Small trauma, small cut. Faster recovery. Yes, and easier burden. I must mention, however, that not every patient qualifies for minimal invasive. There are certain, the majority ones. Now we have so much experience in our program that, for example, almost every mitral valve can be operated minimally invasively, endoscopically. Every aortic valve can be operated like that, almost every. Bypass is not the same, maybe 50-60% of the patients, because some patients don't qualify. Patients who have very severe calcifications on their aorta, who have a unfavorable anatomy. We see that on the preoperative CT scan, for example, okay? The scans before the surgery. Patients with severe vascular disease, all the vessels turn into stone, so to speak, unfavorable, so you cannot cannulate, you cannot get in the way you should. Very bad heart function, that means very, very advanced disease. These are situations where we wouldn't advise the patient to do the minimal invasive, but rather go with the traditional method, which we have in our portfolio, of course.
So that would be basically a situation where you have to open and go to many areas inside. And that's why you open up traditionally.
Now, actually, you can reach every area of the heart with a minimal invasive.
Right.
But if, let's say, the arteries are very small, very calcified, very diseased, in very dysregulated diabetic patients, for example, then it can become difficult. And what you want to guarantee, ultimately, is the best possible result in the long run, stitch nice bypasses. And, so, as I said, however, more than half of the patients qualify. So my advice to the patients, talk to us, talk to their surgeons, the doctors, do they qualify for the minimal invasive, and they will be told.
Okay. I've always wanted to ask someone like you, Professor, this question.
A heart surgeon?
Yes. Because we've had cardiologists on the show before,
we have.
And I haven't asked them this question.
Ask.
And I'm sure it's on people's minds. How strong is the human heart?
Wow, that's a beautiful question. Actually, the human heart is quite a noble structure. It has a symbolic function, first of all, not only a pump function. If I tell you that the human heart in a lifetime propels forward as much blood as you would need to fill a huge oil tanker ship.
Wow.
About 270,000 tons.
Wow.
It's an amazing pump that lasts very, very long. It pumps along for 80 plus years without failure. It's quite a feat of nature. The first 4-chamber heart was discovered in a Thescelosaurus, a dinosaur that lived more than 100 million years ago. And even then, nature knew how to produce a pump that will sustain a huge organism. It's pretty impressive, and certainly one of the reasons some of us, dedicate our lives to it.
Okay, so I mean, you're the perfect person to ask this as well. To how can we keep our heart at its optimal health?
Yeah, well, exercise I would get, moderate exercise, don't exaggerate, okay, good diet, certainly management of stress, all the usual things we hear here and there or in the social media, they do apply.
I caught that, Doctor, Professor. You said don't exaggerate, which means if you overwork your heart by doing exercise, that's also bad.
It's bad, yeah, I would think so. I mean, exercise is good and builds up new vessels and increases and improves the oxygen and blood supply to the heart. But anything that is far beyond the mean, unless you're a professional athlete, may not be good after all.
Not necessary.
Okay, let's go back on air.
Kiss 92 traffic.
On the PIE towards Tuas after the KPE exit, look out for a vehicle having some trouble there. And also on the SLE towards the BKE, an accident after Woodlands Avenue 2's exit. Wherever you are, stay safe this morning.
Good morning and welcome back to The Big Show and The Big Show TV. Our guest for this morning is Professor Theodoros Kofidis, Cardiothoracic Surgeon from Mount Elizabeth Hospital. And next week is going to be an especially exciting week for you, Professor, because the annual International Conference of the Asian Society for Cardiovascular and Thoracic Surgery is happening. And you are going to be the president of this meeting. Tell us more.
Yeah, that's true. We're very excited. We excitedly look forward to that. We've been preparing this international conference for 3 years now. It's basically the Asian Society, as you mentioned, but this year it's going to be a joint event with joint sessions with the American Association and the European Association. Literally, the whole world of heart, vascular, and lung surgery is merging onto our beautiful red dot next week at Suntec. Where the best and newest techniques, technologies will be shown and taught. We put in workshops, hands-on training workshops from doctors around the world. And of course, laymen are also invited to attend. It's going to be a big event. We should put Singapore on the map of heart, vascular, and thoracic surgery around the world.
Amazing. It's a 4-day event, huh?
It's a 4-day event. For the president, it's not easy, as you can imagine. You are the first to wake up and must entertain the whole day and the last to go to sleep.
Yeah.
You should go on a short holiday after the event.
I thought about it, actually. We have a lot of attractions around Singapore.
We do. Okay, so Professor, we're talking about minimally invasive surgery. Can you walk us through what the process is like for someone who might need to get it done soon?
Okay, first of all, a patient gets in touch with his surgeon and we have a consultation or teleconsultation. Then we assess and evaluate whether this patient qualifies for minimal invasive and endoscopic. Indeed, most of the times he does. Okay, so the next is to appoint a date for the surgery. Minimal invasive heart surgery is perhaps not the best idea for very tough emergencies. That means you have to bring the patient to the OR now, otherwise you lose him. So it's more for elective surgery. But most of the surgeries are elective. That means they can be planned and discussed and planned. Once the surgery planned, usually patient admits the day before. Then the next day we do the surgery, we set up the equipment. Surgery takes about 3 to 4 hours depending on the nature of the surgery. Then the patient goes to the ICU. Then out of the ICU the next day goes to the general ward, 3-4 days in the general ward. And we like to work with our patients pretty intensely in terms of physiotherapy and rehabilitation. Laziness should not be there in the post-operative period. Both of us work hard, patient and doctor, to put the patient on his feet and get him moving. By the time the patient leaves the hospital, he's independent already.
Right.
Yeah, going to the bathroom, can make himself a tea, a coffee. We shouldn't view the patient after surgery as a personal vase, sit at home and wait to be treated. He should move, stay mobile, improve by the day.
Okay.
For those people who are not listening to us on the, or rather watching us on the Big Show TV, I asked the doctor just now. I asked the professor just now, how strong is the human heart? Because that's a question that many people have been asking us.
Yeah.
And it was an amazing answer. Could you tell everyone what you said just now for the people who are not watching us on the Big Show TV? How strong is the human heart?
It's a very strong muscle, and the beauty of or the strength of the human heart is not solely in the power it produces. It's so intricately built. It's a helix, it's an oval shape, and the muscle layers within the heart muscle are intertwined in such a way that it produces a lot of power. Had the heart been just a sphere, that means a ball,
yeah,
it wouldn't be able to pump so well. And on top of that, it pumps for 80 plus years, propelling as much blood as to fill out an oil tanker of more than 270,000 tons.
So its shape is its most important design element.
I think so. The shape, the helix of the heart, that means the oval shape and how the
chambers,
the chambers are built and intertwined, is the key for its function and its robust and sustained function over so many decades.
Nature is incredible.
Amazing. Let's take care of our hearts. Let's continue to talk to the professor on the Big Show TV. Meantime, here's Niall Horan with Heaven on Kiss 92.
So, Professor, we've spoken about the whole process of endoscopic heart surgery, but what kind of conditions can this endoscopic heart surgery treat?
All conditions any other heart surgery can treat.
Okay.
That means mitral valve diseases, mitral valve regurgitation, leakage, mitral valve stenosis, blockage, aortic valve blockage or regurgitation. That means aortic valve surgery, mitral valve surgery, tricuspid valve surgery, irregular heartbeat that requires surgical treatment, and coronary artery disease as well. Sometimes we take small and benign tumors out of the heart through a minimal invasive procedure, endoscopic procedure. We close holes between the chambers of the heart. So all the usual conditions that are treated through the traditional median stenotomy. As I said, for the patients who qualify, they can be treated with the endoscopic way. Now, minimal invasive and endoscopic is, of course, a more high-tech operation. It's more elegant in my eyes, okay? So it requires a special setup. That means camera must go in and special devices and suctions must go in. So you spend a few more minutes setting up nicely, but then it becomes an elegant operation with beautiful visualization of the structure you want to operate on. Beautiful visibility. Some of the naysayers or the people who don't know minimal invasive yet or are not informed enough, they think that by a minimal invasive hole, the keyhole, you can see the heart very well and all this, which is absolute nonsense. Okay, so once you know how to set up, then you have a direct, spot-on visibility of, let's say, the mitral valve or the aortic valve. And in some cases, I believe you can even do a better job.
Wow.
Wow, incredible.
So when you do your surgery, Professor, is it robotic?
Yeah, good question. So the minimal invasive heart surgery contains 2-3 different domains. It's endoscopic, that means using a camera to look inside. It's hybrid, that means I do half of the bypasses, cardiologist comes in and puts in the stents to complete the procedure. Hybrid means mixed, combined between the two. And then robotic. All these are permutations of minimal invasive heart surgery. The robot is a different deal. It's a device, basically. Actually, the word robot or robotic is not pretty accurate. It's not an actual robot. Robot means you program it and it can do it itself.
Right.
But it doesn't. It's just a joystick and telemanipulation system.
There's still a human behind it.
Human behind and moving the sticks. So it's not quite robotic. I helped start the program in NUH many, many years ago with a robot. But nowadays, with the endoscopic method, the cuts are so small, the operation is so much faster, cheaper, and can be also more extensive in terms of you can address many conditions at a time without the robot, that the robot is largely unused or abandoned around the world. Now there is a renaissance coming in because the robots have changed. You don't need too many arms. Until now, you had to make many more holes to put in the arms of the robots inside. So I don't know what is more burdensome for the patient after all.
Right.
There is a renaissance. Perhaps new generation of robots will come out, so it will be revived.
Well, do you think the robots will ever replace the surgeons?
No.
Well, I would hope to say no, but looking at the overall, improvements, developments, AI, robotics, it's just amazing. I wouldn't dare to say no. Maybe, perhaps not in the next 2 decades, but
at some point,
at some point down the road, you'll be surprised. Yeah.
Yeah.
Professor, I think you're connecting very, very well with all our KISS 92 listeners. And you've been mentioning like when you were NUH and all that. So how long have you been in Singapore?
Well, actually, I'm Singaporean.
There you go.
Okay.
It's everyone.
Since 2013. And I spent, so far, 18 years plus, almost 19. Yeah.
Yeah, wonderful.
I have a question. You mentioned sometimes you need to take out tumors from the heart as well. Heart cancer is not something we hear of very often. Is it something that we see here in Singapore?
Thankfully not. Thankfully not. Heart cancer is very, very rare.
Okay.
And why? Because the heart itself, the heart muscle cells, they don't replicate often. They don't replicate strongly. That means I cut your liver, your skin, it will regenerate. The heart doesn't.
Oh, right.
So the good side of it is that it doesn't form cancers.
Oh, okay.
So it doesn't replicate so aggressively, it doesn't proliferate,
doesn't regenerate.
Doesn't produce cancer so easily.
Oh.
I'm using simple terms for our audience, not the most complex scientific terms, but that's the reason why we don't see cancers in the heart. But we do see benign tumors like myxomas, fibroelastomas, and these are very easy to take out. Now, personally for me, with all due respect to the traditional heart surgery, open up a patient and a chest bone just to take out a myxoma or to close a small hole in the heart is a shame.
It can be done in such a better way.
It can be done so easily, with a small hole in the side. It's a 1.5 hour operation on the heart.
1.5 hours.
Compared to what? I mean, traditional compared to minimally invasive? How much time difference is there?
There isn't much difference.
Okay.
I mean, it depends on how experienced you are. And there are different kinds of surgeons. We all have a mixture of those attributes. I mean, there is the brainy surgeon, there is the manual surgeon, and there is the solar plexus surgeons, the chi surgeon who goes in and just flies.
Wow.
There are different kinds of surgeons, and we all have elements of all three. One more, one less. So it depends on the surgeon also, how fast it goes. But remember, and that's very critical to mention, it's not about the speed.
Okay.
It's about safety of the patient, efficacy of the procedure, good, robust, long-term result, and that's the most important thing.
Okay.
All right, we're going to go on the radio one last time.
I got a question.
Kiss 92 traffic.
If you're on the ECP heading towards the airport after the Fort Road exit, look out for a vehicle that's broken down. Also on the AYE towards the MCE after Yuanqing's entrance, another vehicle has broken down. And on the SLA towards the BKE after Woodlands Avenue 2's exit, an accident. If you have anything else, 8855
Good morning and welcome back to The Big Show and The Big Show TV. It is Good Morning Doctor Day, and today we have Professor Theodoros Kofidis, Cardiothoracic Surgeon from Mount Elizabeth Hospital. I'm so proud to call him my fellow Singaporean, and he is absolutely brilliant.
And we have a question from one of our viewers. Haida says, "Hi, Professor. For a male 56-year-old patient with 75% of blocked arteries on the left main vein, will he be suitable for this keyhole minimal heart surgery instead of having to go through open heart bypass surgery?"
Absolutely. I mean, first of all, the patient needs to be assessed by his cardiologist and then have a consultation with us. Then we look, as I said, at the scans. We'll look at the extent of his coronary artery disease, and we decide together whether he qualifies or not. But why not? Yes. As I said, there is a high likelihood that the bypass surgery can be conducted in a minimal invasive fashion.
Okay, perfect. Another one. My late mom had no history of heart disease. Her ECG was normal. However, it was said that she had blocked vessels. Can such an incident happen out of nowhere?
It's not out of nowhere. Sometimes the disease doesn't manifest, doesn't come out to the surface, but doesn't mean doesn't exist and slowly developing inside. That's particularly the case for diabetic patients, where the disease can develop faster and more aggressively. But anyways, yeah, many times we don't have symptoms actually, and we discover the disease by coincidence, by a regular checkup. So, yeah, we should be alert following a certain age, do our checkups, talk to our cardiologists and heart surgeons, and we take it from there.
Okay, and then a final question from Benjamin. One of the most important questions for this morning, I think. What exactly is a broken heart?
Well, in which terms? Philosophical terms?
Or emotional terms? Yeah.
Emotional terms, yeah. That's what we associate with a broken heart. But no worries, we're here to mend it. Me and my colleagues, heart surgeons, cardiologists in Singapore and beyond, we dedicated our lives to helping our patients. Therefore, we mend broken hearts. God willing, with God's help, we're always there to help.
Right. Oh, amazing.
By the sounds
answer.
of it, for us to have a healthy heart, one of the most important things is to be happy.
Yes, no stress.
Right?
Yep, as little stress as possible, and stay active.
Absolutely. Before we let you go, Professor, I know you've done many surgeries and all that, but do you have a surgery that you can tell us about that you're most proud of?
Well, there are so many indeed, and each one is different. And I'm proud of my patients. I'm not proud of myself and my surgery, but certainly you get a huge sense of accomplishment, particularly people who are one step before failure, heart failure, one step before leaving us, and you interject basically with tools and your hands, and you help this patient restore and recover. That always gives you a sense of accomplishment. But I think we enter the operation theater, all of us, with a certain humility and respect to the human and the human tissue. So I wouldn't speak of pride, but there are so many. And I remember particularly a teacher here in Singapore, young lady, who was affected by infectious disease, affected her heart, heart failure. She almost died. And with amazing teamwork, we managed to bring her back and to restore her. I think that's one of the cases that I still have in mind and I'm thankful for.
Thank you for saving all those lives.
Yeah. Thank you so much, Professor, for doing what you're doing. You will be greatly blessed. And all the best for the annual international conference of the Asian Society for Cardiovascular and Thoracic Surgery happening next week, of which you are the president. And 4 days of really hard work. Please have a good rest.
Thank you very much for your hospitality. It's been a pleasure.
Thank you so much, Professor.
You've been listening